Good afternoon, everyone. My name is Jason Jim, one of the neurosurgeons here at Children's Hospital Los Angeles, also assistant professor of neurosurgery at the Keck School of Medicine at USC. And thanks everybody for staying late. And I'm here to talk a little bit about some of the new advancements in the surgical treatment of pediatric epilepsy. So as we all probably know, there's over 3 million Americans that are suffering from epilepsy, with somewhere between 70 to 130,000 newly diagnosed patients per year. And about a third of these patients will end up becoming medically intractable. And what that means from a medical side means that usually after a trial of 2 different seizure medications, the addition of a third or fourth medication may not help in terms of seizure control. And these patients end up becoming potential candidates for epilepsy surgery. And we know from a lot of previous studies that epilepsy surgery can be actually very beneficial for long-term seizure control. But despite that, this is a very underutilized treatment, with less than 1% of epilepsy patients being referred for surgery. And there's this table below is from a paper that looked at some common misconceptions about epilepsy surgery, which may end up being a barrier for referral. Some things like you need to try all different types of all the types of seizure medications, or epilepsy surgery can make my memory worse. All of which a lot of our data from epilepsy surgery suggests that these end up being misconceptions, and some people can actually do better with their seizures controlled after surgery. Another aspect of epilepsy surgery includes the economic aspect, where several other studies have shown that the long-term economic benefit of epilepsy surgery can be very helpful. And even though epilepsy surgery has a high upfront cost, which can involve not only pre-surgical workup, but the surgery itself, the long-term effects can be seen as early as 1 year after surgery. So when we think about epilepsy surgery, there is an entire workup that has to be completed. But to focus really in on when we think about epilepsy surgery, we think about things like intracranial monitoring, where electrodes are placed directly on the brain to better localize and try and find where the seizures are starting from in the brain. And this may end up leading to something like resection, where the bad parts of the brain where the seizures are starting from are removed, or something like neuromodulation, where we're able to control the seizures through some form of stimulation. And over the last probably 10 to 15 years, I think epilepsy surgery has really taken off. And there are definitely a lot of centers around the country that are working on advancing epilepsy surgery, not only from an adult, but also pediatric standpoint. And a lot of epileptologists and surgeons have focused on making things safer for the patient, making things less invasive, making things more efficient for the patient, and in the kind of same realm as safety, minimizing the risk of injury to the brain. As well, we've also discovered other techniques, other surgical options that can help control epilepsy through a neuromodulatory mechanism. And this provides an alternative option in terms of just cutting things out. So I have a couple of cartoons here from the early days of brain surgery, but we've definitely come a long way to something a little bit more modern, as you can see here. So when we think about intracranial monitoring, one of the most recent advances is something called stereoencephalography, or stereo EEG, or SEEG. And essentially, when we think about intracranial monitoring, our goal is to try and localize and best find out where the seizures are starting from by placing electrodes directly onto the brain to help us record seizures. And the gold standard of this has been something called a grid, where essentially a grid of electrodes or a strip of electrodes are laid directly on the surface of the brain. And while this has been the gold standard for recording seizures intracranially, it does require something called a craniotomy, which is a fairly large and invasive procedure where there's an incision that needs to be made in the skin, a large piece of bone needs to be removed. The covering of the brain called the dura needs to be opened to allow us to get access to the brain. And through that, and that allows us to place those grids and strips onto the surface of the brain. The downside of this is that there's associated risks with things like craniotomy, and these can include pain from the incision, bleeding, risks of infection, risks of something called cerebral spinal fluid leak, as well as injury to the brain, because even though we're placing grids on the surface, there is risk that the brain can get injured from the procedure itself. And so this has led to the stereo EEG procedure, which involves placing electrodes into the brain. These are called depth electrodes, but they're placed via very, very small incisions, usually only a couple millimeters in size. And I have a little cartoon on the left here where on the right, where there's a tiny incision in the first black line, which is the scalp, and a small hole, usually about 2.4 millimeters, is made within the skull to give us access to the brain. Through that 2.4 millimeter hole or burr hole, we secure a little anchor bolt, and then a tiny 1.8 millimeter electrode is then placed in the brain. But this electrode, even though it's tiny, allows us to record several areas of brain activity. And in comparison to something like a craniotomy, this is definitely less invasive, less painful, lower risks of hemorrhage into the brain with a less than 1% risk of hemorrhage per electrode, and as well as a low infection risk, like 1% per procedure. So overall, pretty advantageous. And additionally, it gives us pretty significant flexibility here to study multiple areas of the brain, multiple lobes of the brain. We can study both sides of the brain. We can also study deep structures within the brain and avoid the need for something like a craniotomy or a very large procedure to get electrodes in. And this is actually a cartoon that demonstrates how stereo EEG or SEEG can be used to study different areas of the brain, including multiple different lobes, deep structures, and all in a less invasive type of way. Over the last 5 years, a lot of centers have focused on stereo EEG, and these are some papers, recent papers that suggest that it can be very, very helpful in terms of identifying where the seizures are starting from, and especially in pediatric patients. So once the seizures have been identified and the area has been localized, the traditional way to address this is to proceed with something called surgical resection, where that portion of brain is surgically removed. But more recently, another type of technology called laser interstitial thermal therapy, or LIT, has come about that can do the same goal of surgical resection in terms of addressing where the seizure is starting from through a minimally invasive type of way. So what this is MR-guided laser ablation of the seizure focus. And this is technology that was FDA approved in 2007. And once again, this is a minimally invasive type of neurosurgery. We think about it using very, very small incisions and very, very small holes like our stereo EEG electrodes. The purpose of this procedure is to get a tiny laser fiber into where we believe the seizures are starting from. And through that laser fiber, the tissue is heated up to or greater than 60 degrees Celsius, where that tissue is quote unquote ablated, and it results in tissue coagulation, that area being destroyed, similarly to how we would do in an open surgical resection. The laser ablation technique kind of relies on 3 different things. One is the placement of the laser fiber. The second thing is when the procedure is done, it's done within the MRI scanner. So we get real-time feedback in terms of the temperature of the tissue in the brain, and as well as things like the areas that are ablated. And then finally, there's a workstation console that helps us control everything, and not only allows us to monitor areas that are ablated, but also provide safety markers for areas that we want to protect from the laser and the heat that the laser generates. So as you can see, this is a more minimally invasive type of way of doing surgical tissue destruction. And sometimes you can address the area with one lasers, and in this case, we have 4. So, but once again, they involve very, very tiny and very small incisions. So this is an example of the type of a type of laser ablation. So on the left here, what we see is something called MRI thermography. So what the MRI is doing is giving us feedback in terms of the temperature of the brain. This black line that we see here represents the laser fiber. And on the right here, there's an estimated area of ablation. So in this case, we can see that the temperature on the left here, the temperature has changed color, and it kind of we have a little gradient on the top right that shows us the temperature. And based off that temperature, the computer is able to estimate the amount of area that's ablated. That shows up as orange on the right there. And once again, this is very beneficial because we're able to get real-time feedback in terms of what we're doing and the area that's ablated. So these also have multiple different applications. So lesions that are closer to the surface can be very easily addressed. But more importantly, areas that are deeper that would require a big surgical exposure, or ones that are riskier to get to, where normal brain has to be traversed, can be addressed with laser ablation. So in this case, on the left, we're targeting an area called the insula, which is hidden away deep in the brain. And on the right, there's a lesion called a hypothalamic hamartoma, which is located essentially in the center of the brain and can be very, very difficult to get to, both from a surgical standpoint. This is actually a paper that looked at the use of LIT in pediatric epilepsy surgery, and that definitely is becoming more popular for treatment. So things like hypothalamic hamartoma, cortical dysplasias, tuberous sclerosis, even things like mesiotemporal sclerosis and tumors that are causing epilepsy have become much more readily treated with laser therapy. Now, both of those technologies are coupled with something called robotic assisted neurosurgery. And essentially what this is a stereotactic robot. And on the right, this is the most common type that's used, called the ROSA. And what this robot allows us to do is accurately and efficiently place either stereo EEG electrodes or the laser fibers, and usually within about 1 millimeter of our intended target. So very, very accurate. And when we talk about things like stereo EEG, where multiple electrodes need to be placed, the use of this robot has definitely helped reduce surgical time, even cutting some surgeries from 6 hours down to 2 hours. So there's a couple things that we consider. So the first thing is planning trajectories. Where do these stereo EEG electrodes go? Where do the laser fibers go? And this is done on a workstation using the MRI scan that's obtained before surgery. Once that's done, the patient is then co-registered to the MRI scan. And within the operating room, the robot is able to find the entry site within for the specific trajectory for the laser fiber or the stereo EEG electrode. And it assists us in ensuring that our stereo EEG electrode or a laser fiber is going exactly where we want it to go. So this has actually been very, very helpful in terms of epilepsy surgery. And finally, I want to talk a little bit about advances in neuromodulation. I think Julia may have touched a little bit about something called responsive neurostimulation, or RNS. And what this is a surgically implanted neuromodulation device that was recently FDA approved for drug-resistant epilepsy with focal onset disabling seizures and less than 2 epileptogenic foci. The current FDA indication is for patients 18 years of age or older, but there have been a lot of off-label use for those less than 18, with a minimum age probably somewhere between 12 and 14. So what this is a surgically implanted device where two permanent electrodes are actually placed for long-term EEG. And there's a couple of different options. One of them includes a strip, and one of them includes a depth electrode. And the purpose of this is to monitor areas that we believe are responsible for seizures, for starting the seizures, but are areas that are what we call eloquent, meaning that they serve a lot of function, and surgically removing that tissue may result in some sort of deficit like weakness or trouble with speech, trouble with memory. Additionally, areas that have patients that have seizures on both sides of the brain, this may be a good option for, where surgery on both sides of the brain, such as bilateral mesotemporal sclerosis, may result in fairly severe memory deficits. So these electrodes are surgically implanted, and then they're attached to a battery on the skull, and the whole device acts as a long-term device that monitors the brain waves. And what's really unique about this, and I have a little cartoon here, is that it actually records and detects seizures. And once the seizure is detected by the RNS device, as you can see here on the video, when the seizure is detected here, it actually sends a stimulation to halt and break up that seizure. Sorry, I think the video froze. So here, the seizure is detected, and some stimulation is delivered by the RNS device to halt the seizure and its propagation. And the device actually is able to record these EEG recordings, and these recordings can then be downloaded and reviewed by the epilepsy team to help the RNS device learn what the seizures are for this particular patient, and over time help to decrease the seizure burden. So this is actually a recent paper from a group out of New York that looked at responsive neurostimulation in pediatric patients. And even though they had a smaller number of patients implanted because the RNS was being used off-label, there was a pretty significant group of patients that experienced at least 75 to 100% decrease in their seizure frequency. So overall, pretty exciting technology. So in conclusion, medically refractory epilepsy can affect up to a third of patients with epilepsy, and these patients should be considered for epilepsy surgery. Recent advances in epilepsy surgery include the use of stereo EEG, the use of laser interstitial thermotherapy, robotic assisted neurosurgery, as well as RNS neuromodulation. And a lot of these are moving towards minimally invasive surgeries that are really well tolerated and can be successful in treating epilepsy.